Robbie!
Whoa, what's going on here?
I disabled my ankle monitor because it was going off and our ability to help patients during the mass casualty.
Tell that to your judge.
This is my resident. I need her. Call Gloria. Can you at least wait a second, speak to our chief medical officer?
No, but they can call the department if they have any
We
questions.
just came through the worst mass casualty incident in the city's history, and you two are around with this? Are you serious? You don't have anything better to do?
The context is that she drilled an intraosseous needle through her ankle monitor as it was beeping randomly. These officers are sent to arrest her for tampering with the device.
Officer Harrelson, can you please?
Is there a problem here?
She disabled her ankle monitor.
It was malfunctioning.
She's in a custody battle with a restraining order and is considered a flight.
So, it's finally revealed that she is in a legal dispute with her ex-partner over the custody of her son, and the court has ordered her to stay away from someone, likely the ex's current partner, I guess. Authorities believe there is a chance she might try to escape, run away, or leave the jurisdiction to avoid legal consequences, so they kept her on the ankle monitor.
That's bullshit.
You're interfering with our ability to treat patients. I'm not sure we could have saved Officer Stefano if she hadn't disabled the damn thing.
That true?
They saved Stefano's life. They saved a lot of lives.
That's a good reasoning provided to the police in the setting of a mass casualty. Don't know if that would be considered a valid reason later on in court.
Take care of this first thing tomorrow morning.
I swear.
Take the cuffs off.
Thank you.
Thank you.
Thank you for everything you did here tonight.
Do I even want to know?
Probably not.
Good. What's your status down here?
We have had 112 mass casualty patients come through here in the last 3 hours. Only 6 people that we couldn't save. They're still in our makeshift morgue and peds.
Sadly, doctors would only remember the patients they lost, as they would make an indelible impression on their minds, not the ones they saved, as it would be eventually brushed off as part of the job.
71 people went upstairs last I heard. Surgery had stabilized the 39 most critical red zone, 32 pink zone patients. We also had 24 yellow zone patients, many of whom are getting orthopedic surgery as we speak.
Ortho, trauma, cardiothoracic, and general surgeons get the most cases, maybe a few neuro cases too here and there, if there is a mass casualty involving shooting.
The police are still interviewing everybody else that's still down here. We discharged 8 people, and I don't know the status of the green zone patients because I wasn't there. You'll have to check with family medicine.
Impressive. I need you and Abbott to turn your patients over to the night shift now. And then, oh, sorry. What? No, we need to be back up and running now. Tell security to open the ER doors for walk-ins. If you've got a triage nurse and registration clerks, you should already be open.
Typical administration, they're not letting ER staff have some rest and some breather after such a mass casualty. Even the ER team that arrived for the night shift deserves some rest now.
You ready to give this measles kid to Dr. Shen and go home?
Oh, no, I'm okay.
You sure?
Yeah. It's just, we repeatedly tried to explain the importance and low risk of the spinal tap, and the parents they're risking their son's life.
For context, the patient here is a child who contracted measles from his sister. He is in the resolution phase of measles, however, has contracted pneumonia and sepsis, and is suspected of a complication called acute demyelinating encephalomyelitis. That involves demyelination of CNS neurons, causing altered consciousness, and can cause seizures, coma, and even death. A lumbar puncture is a perfectly safe procedure with no risk of paralysis. If the procedure is correctly done as the level L4, L5, or L3, L4, which doesn't contain spinal cord, as it ends at L1, L2, well above.
Hopefully they'll come around.
And if they don't?
We do the best that we can. Some things are out of our control.
Yeah, and if patient refuses treatment and wants to go home, they have the autonomy to do so, but they gotta sign the leave against medical advice form.
Dr. Shen, how are we progressing in here?
No improvement in the patient or his family.
Where is your wife and daughter, Mr. Edwards?
My wife took Georgia to the bathroom.
Okay. Well, your son Flynn is critically ill. And the longer that we wait, the worse this could get. Without the spinal tap, we don't know the best treatment to give him the best chance of recovery.
A spinal tap would help differentiate ADEM from other viral or bacterial causes of encephalitis. A mild lymphopoiocytosis, along with mildly elevated protein, normal glucose, and negative bacterial culture and viral PCR, would make the autoimmune cause of encephalitis more likely, so that we could start with steroids to suppress the autoimmune reaction in the CNS and save his life. Now, if it's not an autoimmune reaction and it's it's just viral or bacterial infection in the brain along with pneumonia, the steroids would only worsen the situation here, and the patient could die of encephalitis or pneumonia as the body's immune system is suppressed with steroids, with no benefit but only harm.
What's going on?
We were discussing the options for treating your son.
He already looks better.
He is not. And by refusing the spinal tap, we don't know how to help him. The steroids could kill him. If it's just pneumonia, the steroids could save him if it's ADEM. And the longer that we wait, the greater the risk of him dying.
The child is also at risk of neurodevelopmental delay and even blindness and deafness as long-term consequences growing up.
Flynn might die.
No, honey, he's just got a worse version of what you had.
It's not even about death. If the patient somehow survives this episode of ADEM, and yes, ADEM is usually monophasic with a single episode, he is at risk of neurodevelopmental delay and even blindness and deafness as long-term consequences growing up that could change his life forever if he doesn't receive treatment now to decrease this possibility. Some patients or patient parties never try to understand what we're saying.
I'll keep him intubated, hydrated, and pumping the antibiotics. I'll let you know if anything changes.
Mr. Edwards, may I speak with you outside, please?
Go. I've heard enough.
Tell me about your son.
He's a great kid. He's kind, he's very good to his little sister.
You two close?
Yeah.
Does Flynn play any sports?
Baseball, soccer, basketball.
David?
My wife doesn't want him playing football or he'd be doing that too.
Do you get to many games?
I'm doing my best.
Identification.
I guess Dr. Robbie is trying to say that his son could be in the morgue too if they don't allow for proper diagnostic tests and delay his necessary treatment.
These are the people from the Pitt Fest shooting that we couldn't save today. We couldn't save them. But we can still save your son.
You're an asshole.
Yeah. I'm an asshole. I was trying to save your son's life.
The guilt of not denying treatment for your child would only become overwhelming once they are gone. Then, the only thing stubborn parents do would be to blame their doctor for it, rather than blaming themselves for refusing the care of their child when there was time.
Still need charts for 2 patients in North, 3 in South.
All right, we're on it. Just give us a hot minute. Hey, Leanne, can you check out the one she's talking about? It's a code tan.
We know code blue for cardiac arrest or code silver for an active shooter, code pink for infant or child abduction or a medical emergency involving a child, code orange for hazardous material spill, code black for bomb threat, and so on. Code tan or brown could mean external emergency outside a hospital or an unsafe hazardous condition.
Illness or injury in a public area of the hospital, usually a fainting or a fall. Hey, Gloria wants day shift. Get out of here sooner rather than later, so wrap it up.
Gotcha. Repeat labs back on our Blue Man Max, running through agents that cause methemoglobinemia, mainly drugs and toxins.
As discussed earlier too, the causes of methemoglobinemia does include drugs which can act as oxidizing agents to convert hemoglobin's ferrous iron into ferric state. These include nitrates like nitroglycerin in high doses or nitrites including poppers, the recreational drugs which include amyl nitrite, butyl nitrite, and isobutyl nitrite, local anesthetics like benzocaine, prilocaine, and lidocaine, antibiotics like dapsone, sulfonamides, nitrofurantoin, antimalarials like chloroquine and primaquine, nitroglycerin, or certain antibiotics like sulfonamides could cause methemoglobinemia. Even exposure to aniline dyes or industrial chemicals including benzene can cause it. There could be nitrites in well water or foods too.
Yeah, drugs like topical anesthetics from the dentist, antibiotics to treat malaria, leprosy.
She is talking about dapsone, an antibiotic drug used in leprosy, besides antimalarials like chloroquine and primaquine.
Okay, I can see if he's taking any of those.
Also asked about industrial toxins, aniline dyes, benzene.
Aniline dyes are used in textiles, printing, rubber, and pesticides. Workers in industries with this dye exposure are at risk. Pure benzene itself is mainly hematotoxic, meaning it can cause aplastic anemia and leukemia risk, but its oxidized derivatives like nitrobenzene, aminobenzene, or aniline are the ones which can act as oxidizing agents and cause methemoglobinemia. In nitrobenzene poisoning, there's a bitter almond odor and features of methemoglobinemia like chocolate brown blood with cyanosis unresponsive to oxygen.
There's also food additives, nitrates, nitrites.
Nitrates and nitrites are used in preservatives, cured meats, and also in fertilizers. These could also contaminate well water. Infants are especially vulnerable to the effects of nitrates and nitrites, and this is called blue baby syndrome. Sodium nitrite is used as a meat preservative, and in large amounts, this can cause methemoglobinemia. Certain artificial coloring agents in food can also cause methemoglobinemia.
Some of those are available online as suicide kits.
Nitrites, especially sodium nitrite, have unfortunately become a known method in some so-called suicide kits, often including a mixture of sodium nitrite powder with an antiemetic. It's abused this way because it's readily available as meat preservative. It is a potent oxidizing agent which rapidly converts hemoglobin to ferric state and causes methemoglobinemia. Even small doses, that is a few grams, can be lethal.
I think he may have tried to hurt himself.
Maybe. Or he was poisoned. I had a guy today whose wife was spiking his coffee with progesterone.
Jesus, and I thought the crazies were for the night shift.
She wasn't crazy, just desperate.
The case they're talking about was a case where the father abused her own daughter and the mom started putting progesterone pills in his coffee to decrease his libido by suppressing the HPG axis via negative feedback, in turn decreasing testosterone production from the testis. The unintended effect of this was he developed gynecomastia due to the effect of progesterone on breast tissue.
Help! Police! Officer, I'm being held here against my will.
What else do we know about him?
Nothing, really. He was too groggy to talk, but I can give it another shot.
Go for it, Sherlock.
Will do.
Last pink patient going upstairs.
You two hanging in?
Oh, yeah.
Okay, start wrapping it up and then hand off what you have left to the night shift.
Can we talk?
Go home. I don't want to tell you again.
You needed me.
Do you have any idea how much trouble you're in?
The context is that he stole Librium pills from his patient and is likely a benzo addict. This perfectly fits his personality shown here, the guy who thrives in the adrenaline rush of the ER, finishes cases quick, a great resident for the ER, but likely uses benzos to calm himself down.
Only if you report me.
I'm gonna pretend
Robbie,
that I didn't.
pelvic crush injury.
Don't even think about it. Thought we were close to trauma.
This is the code tan. He got pinned behind a truck backing up with replacement supplies.
100% non-rebreather. Let's drop 120 ketamine, 100 of rock, and page trauma surgery, please.
Anesthetics and muscle relaxants given to sedate the patient or for procedural sedation. The patient must be in excruciating pain.
Where the hell did this guy come from?
Our loading dock.
Okay, I got the E-Fast. Grab a binder. Obvious pelvic fracture.
The external signs raising suspicion of pelvic fracture would include visible deformity or asymmetry of the pelvis or hips where one side is higher than the other. There could be deformity of legs due to the associated fractures. There could be massive bruising or swelling over the lower abdomen, flanks, or upper thighs. However, imaging is needed to confirm like AP pelvis X-ray or CT scan pelvis.
I'm in a lot of pain.
You taking any medications? Any drug allergies?
This is a pelvic binder used to temporarily stabilize the pelvic ring after a suspected unstable pelvic fracture. It reduces pelvic volume and helps tamponade venous bleeding along with decreasing pain and movement. It's positioned over the greater trochanters and tightened snugly until the pelvis is compressed.
Am I gonna be okay?
Absolutely.
We got you, Hector.
BP 68/42, pulse 130. I got a 14 gauge in the left AC.
The patient is in hemorrhagic shock with severe hypotension and tachycardia, most likely due to the ongoing pelvic hemorrhage. They're trying to look for intraperitoneal bleeds. This is the liver and this is the right kidney. Intraperitoneal bleed, if present, would collect between these two structures in the potential space called hepatorenal space or Morrison's pouch. Looks like it is absent here.
Whole blood massive transfusion protocol.
We got whole blood coming in from Erin Youngstown. I'm not sure it's here yet.
Let's go 1-to-1-to-1, red cells, platelets, and plasma. We've got that.
Whole blood contains RBCs, plasma, and platelets in their natural ratios. This replaces blood as the patient is losing it, including oxygen carrying capacity, clotting factors, and volume altogether. In massive hemorrhage, if whole blood isn't available, we give all three separately packed RBCs, fresh frozen plasma, and platelet concentrate in a balanced ratio of 1:1:1. Here, there could be dilutional coagulopathy, but in whole blood, there is coagulation balance as it contains the natural blood composition.
Let's place an IJ after the intubation, please.
On it.
Okay, EFAS negative, it's all retroperitoneal.
An EFAST in the abdomen is used to check for bleeding in the peritoneal cavity that is intraperitoneal bleeds. If it's present, it would collect in the potential spaces for collection in the peritoneal cavity like the Morrison's pouch, splenorenal recess, rectovesical space, and so on. If it's absent and the patient is in hemorrhagic shock, likely the bleeding is behind the peritoneal space, which is in the retroperitoneum. Here there could be injury to the venous plexuses like presacral or internal vertebral. Venous bleeds are the most common source of pelvic bleeds. There could also be arterial injury like to the iliac arteries. There could also be bone surface bleeding as pelvic bones are highly vascular and fracture lines ooze into the retroperitoneum.
No blood at the meatus.
This finding is crucial because in trauma cases like pelvic fracture, straddle injury, or gunshot, blood at the meatus is a red flag for urethral injury. If blood is seen, we suspect that the urethra is injured, so we do not insert a Foley catheter that could injure the urethra even more until urethral integrity is confirmed with a retrograde urethrogram. So, no blood at the meatus means no obvious urethral injury, and it is probably safe to insert a Foley catheter for bladder drainage and urine output monitoring.
Pass a Foley.
Hector, you crushed all the bones in your pelvis and you've got some internal bleeding. We need to sedate you to treat you.
Hurts a lot.
When you wake up, you're not going to be able to talk. You're going to have a breathing tube in your throat.
Can I speak to my wife first?
Afraid we have to move now, Hector.
First unit, PEC cells in the infuser.
So they're gonna intubate the patient to secure the airway. In a case of massive hemorrhagic shock, intubation does allow for controlled ventilation, sedation, and better control of oxygenation, while massive transfusion and pelvic stabilization with pelvic binder are done. This prevents the patient from deteriorating due to hypoxia due to the blood loss. However, intubation can also worsen hypotension with the loss of sympathetic drive and positive pressure ventilation that reduces preload. So we gotta be prepared with fluids, vasopressors, and massive transfusion protocol before induction in such cases. The goal is to make the patient hemodynamically stable and immediately transfer to trauma surgeons or to the interventional radiologist for identifying and fixing the bleeder.
What have we here?
Well, looks like two old white guys poached our patient.
Oh, I know you're not talking about us.
Well, I know he's not talking about me. Crushed pelvis, hemorrhagic shock.
NTP, pelvic binder. I'm doing an intubation about to place an IJ.
A central venous access is required for rapid volume infusion of fluids and blood. Internal jugular is preferred as it avoids interfering with the pelvic field, unlike the femoral vein access. This allows CVP monitoring and gives reliable large bore access. It's often accompanied by an arterial line too for continuous BP monitoring.
You need us?
We got this for now. Hold down the fort, get caught up on the day shift's remaining Pitt Fest patients, and we'll get this guy stabilized.
How you feeling, Mac?
Yeah, I'm all right.
So, we are treating you for methemoglobinemia. Have you taken anything or eaten anything out of the ordinary lately?
No, just some unhealthy food truck choices.
Maybe food preservatives like sodium nitrite or artificial coloring agents used in food could be the cause.
Okay, do you work around toxic chemicals?
Asked to rule out industrial exposure to aniline dye or benzene derivatives like nitrobenzene or aminobenzene that could cause methemoglobinemia.
No, I'm a graphic designer.
Have you had dental work done lately? Used topical pain relievers?
Asked to rule out use of lidocaine, benzocaine, prilocaine, the topical anesthetic drugs which could act as oxidizing agents to oxidize hemoglobin's ferrous iron to ferric 1.
Do you know anyone with leprosy?
Leprosy?
Asked to rule out if he's contracted leprosy from someone and is being treated for it using dapsone, an antibiotic at a dose of 100 milligrams daily self-administered for cases of Pauci and multibacillary leprosy for 6 or 12 months respectively. It could also be used to treat dermatitis herpetiformis, which is a chronic autoimmune blistering skin disease commonly associated with celiac disease. Dapsone can cause methemoglobinemia too. Particularly, its metabolite dapsone hydroxylamine is an oxidizing agent that converts normal hemoglobin into methemoglobin.
Yeah, I don't know anyone with leprosy.
Well, something that you ingested or came into contact with made you really sick, and you could have died. So we need to figure out what caused it so it doesn't happen again.
It won't.
He knows what he took, it seems. Probably the recreational drugs poppers, including amyl nitrite and other nitrites, are what he took. When fumes of these drugs are inhaled, they act as potent vasodilators, producing mild euphoria, warmth, and dizziness, hence are abused for the euphoric high it provides. The methemoglobinemia is the unwanted side effect here, especially if repeated inhalations are taken. Amyl nitrite is a strong oxidizing agent and hence can cause methemoglobinemia, as severe as 50 to 70% of total hemoglobin being converted into methemoglobin. Or this could even be the suicidal kit containing nitrite, given that the drug was taken in high doses and he was in critical state on arrival.
Is there anything else going on in your life that you want to talk about? Anything causing you undue stress or worry?
No. I think I just need a little rest.
The patient clearly doesn't want to admit what he took. Something's fishy. Either it's recreational or self-harm.
All right. Well, I will be back.
This has to be the slowest elevator in the world.
In a hurry to get back down there?
Still a backlog of cases to check on.
Our shift was over hours ago. You don't want to go home and sleep?
I hope this didn't turn you off of practicing emergency medicine.
The good thing about practicing emergency medicine is that you don't take the thought of the cases back home. The shift could be very hectic and you are on all the time with little to no downtime, but once the shift is over, it really is over. Same with radiology. In surgery and medicine though, the cases are still to be taken care by you tomorrow in the wards, so you have to work on the case, think about medications, maybe even answer the call from nurses about the patient progress or deterioration at night, or prepare and learn about surgery or other interventions that could benefit the patient, even though you are literally in your home for rest.
Pretty sure today turned me off practicing all forms of medicine.
I used to feel this the first time I encountered deaths in the ICU of patients that I was seeing. Unsuccessful CPRs, patients being put on the most potent of the antibiotics, and a central venous catheter on the neck, a Foley's for urine intubation and whatnot, and still patients dying despite all those efforts and interventions made me question the futility of those efforts and question my career choices. Later on, the feeling withered away as I learned that medicine does save a lot more lives than it can't.
Everything will be a cakewalk after today. I promise. Come on, let's go find a good case.
Yeah. I'll be right there.
Poor girl, she's super exhausted. The residents are used to the hectic schedule and the hassle. Maybe the interns are too, but definitely not med students.
Central line is in.
Let's hook up the rapid infuser over to the IJ.
A rapid infuser is a specialized machine used in trauma and surgery to provide large volumes of blood products or fluids very quickly, under pressure, and warmed so the patient doesn't get hypothermic. It's useful for massive transfusion protocol, major surgery with expected blood loss, and burn resuscitation or septic shock needing rapid large volume fluid.
And then we can shoot the film.
Clear for X-ray. Shooting. Clear.
Oh, that ain't good.
You got widened symphysis pubis anteriorly.
Disrupted sacroiliac.
The pelvic x-ray here shows what's called a pelvic ring disruption, specifically an open book fracture of the pelvic ring, also called an anteroposterior compression injury. It's likely an unstable anteroposterior compression injury. Here we can see widened pubic symphysis, meaning the separation of the pubic bones wide open, which indicates anterior pelvic instability. We can also see the sacroiliac joint on the left dislocated. A distorted sacroiliac joint means there is either sacroiliac joint diastasis with partial or complete dislocation of the joint, fracture dislocation where part of the iliac wing or sacrum breaks, or there is sacral fracture extending into the SI joint, which can also distort the outline. Here, the dislocated sacroiliac joint has caused posterior ring disruption. This is much more serious because posterior ligaments like sacroiliac, sacrospinous, and sacrotuberous normally provide most pelvic stability. Now that there is pelvic instability due to these two things, the The pelvic ring is unstable, which means the large venous plexus like presacral or branches of internal iliac veins can be torn. This has led here to massive hemorrhage into the retroperitoneum.
Posteriorly. Guy's bleeding like a stuck pig.
I got Dr. Walsh on speakerphone from the OR.
Hey guys, what's up?
We've got an unstable pelvic ring fracture, systolic of 68, eat fast negative.
I thought we were close to trauma.
Hospital worker versus reversing supply truck. MTP and pelvic binder in place.
TXA?
Gave it.
TXA means tranexamic acid, an antifibrinolytic, a lysine analog that binds to the lysine binding sites of circulating plasminogen and plasmin and doesn't allow it to act on fibrin from the clot to lyse it. Basically, it stabilizes the clots that are already formed by preventing their dissolution.
Stable for CT angiogram?
Not at the moment, no.
Keep transfusing.
The blood bank is still waiting on a delivery unless you have some upstairs.
He doesn't need surgery.
Okay, so talking about the management of this particular case. The initial management with pelvic binder for stabilizing the pelvis, reducing the symphyseal widening and tamponade bleeding, massive transfusion protocol, and rapid infusor, and an internal jugular venous access has been done. For definitive management, to control hemorrhage, angioembolization of the bleeding vessel could be done with the help of interventional radiology if arterial bleeding is suspected, like bleeding from the iliac arteries. Here, a catheter is navigated to the internal iliac artery and a contrast dye is injected to find out where the dye extravasates, which would be the site of bleeding. Then, emboli in the form of coils, gel foam, or particles are lodged to block the arterial branch responsible for the bleeding. If there is venous bleeding, which is the most common, or if angioembolization for arterial bleed is delayed or not available, preperitoneal pelvic packing could be done, where large laparotomy pads are placed bilaterally, one along each pelvic sidewall in the preperitoneal space after a surgical incision. The definitive stabilization of the pelvic ring fracture could be done via first external fixation, where a frame is attached to iliac crests. Then comes open reduction and internal fixation, where we open up the pelvis surgically and put plates across the pubic symphysis and fix the sacroiliac joint with plates or iliosacral screws.
He needs interventional radiology to embolize the bleeders.
They don't like unstable patients.
They will tonight. I'll be down as soon as I finish this grade 5 liver lock.
So they're going to perform angioembolization for arterial bleed and then fix the pelvic fracture surgically later.
Hodges, wrist shrapnel. Check. Malloy, leg shrapnel. Yeah. Montgomery, abdominal shrapnel.
She's likely handing over the cases to the night shift nurse in charge.
No. This is supposed to be Chu, female with a headlock. Great. So where the hell she go? Dr. King, Whitaker, there's supposed to be a female Asian patient with a headlock in this bed. Whitaker, I need you to find the patient that's supposed to be here. Chu, elderly female with the headlock.
There was an elderly male with a scalp laceration whose bleeding was fixed with Rainey's clips, the ones used in neurosurgery to control bleeding from the inside scalp before craniotomy. I guess this is a different patient who fled.
Me?
I saw you caught that rat. You're the closest thing we got to a bloodhound. I mean that as a compliment.
Hey, is this a good time?
No, I got a missing patient. You seen a woman with a scalp black, last name Chu?
No, but I need to talk to you.
So talk. You treat a woman with a scalp black named Chu?
Doesn't ring a bell.
You're a lot of help. Start wrapping up and get out of here.
Gladly.
In private.
Keep. What the hell? Well, like I must sleep tonight anyway.
I relate with this feeling completely. If you happen to return home at night after a shift and are supposed to be back to work early morning, you are not going to sleep at all. The only times you'll sleep is if the next day is off. But usually, day duties don't have offs the next day, only night does, at least where I used to work. It also depends on how many groups are there working for the department.
What have you been hearing?
I was screaming and crying. Got a feeling that's going to stick with me for a while.
I mean, about me.
Doctors. Always with the me. Heard you went home early, but you came back, so cutting you some slack this time.
Why? Why'd I go home?
Just figured being a pussy.
What did Robbie tell you?
He told her nothing. The who said what thing is a futile thing to ponder over honestly. But he's likely concerned that his coworkers might think bad about him being a drug addict. That could potentially influence their perspective towards him while working in future.
Dana.
He said I didn't want to know, so I didn't ask. You in trouble, kid?
No, it's just a stupid misunderstanding.
Then no worries. Misunderstandings can be sorted out. Look, everyone's nerves are frazzled from today. Just go home, get some rest.
Robbie believes something that's not entirely true.
That's not like Robbie.
I need you to have my back on this.
Look, I love you, kid, but this sounds like it's between you and Robbie and above my pay grade. Hell, I'm not even sure I'm ever coming back after I walk out of here tonight.
Hectic schedule, low pay, no appreciation for work, no respect from patients, including some even hurting you physically. All these contribute to burnout and forces a medical professional to consider quitting.
What are you talking about?
I'm done. Get too old for this shit.
What? No, Dana, you can't quit. It's like the world is imploding. Dana, you can't quit. We need you. Robbie, me, everybody.
Just gotta wrap things up and get out of here.
I need you to vouch for me. Robbie thinks I'm a drug addict.
Are you?
No.
Isn't he, though? Were those pills for some medical indication? If so, what about the lorazepam vial, which was tampered to take out some IV lorazepam and was likely diluted with normal saline? I mean, if he's injecting IV, he must have developed dependence on the drug and is likely a drug addict.
No, what I am is scared, okay? I'm really scared of what happens next. I up, Dana. And I don't know what I'm supposed to do.
He must be scared because if he gets fired from the residency, which he was about to complete, it was his final year, I guess. That's a bummer. All those years of hard work would just squander away due to this.
You're a smart kid. You figure it out. Trust Robbie, okay? He'll do what's best for you.
What's best for me is being a doctor.